Welcome back to the Masterclass Explainer, everyone. I am absolutely thrilled to have you here for part 19 of our journey. Today, we're setting an authoritative stage for mastering CDT Category 3 restorative coating. Now, if you've been following along with us, you know exactly how critical precision is in the revenue cycle. As billers and coders, we all know the absolute headache of a denied claim, right? Well, today we are taking a laser-focused look at the codes that dictate how we report dental fillings and restorations. We're going to clear up all the confusion around materials, surface counting, and those really tricky bundling rules that can literally make or break a clean claim.
Okay, let's dive right in. Here's a quick look at our strict, rule-based agenda for this session. First, a welcome to Part 19. Then we'll break down amalgam versus resin composites, hit the mandatory inclusions rule, unpack multi-surface coating logic, and wrap it all up with an amalgam code breakdown, followed by a composite code breakdown.
Starting things off with Section 1, welcome to Part 19.
Just to ground ourselves in where we actually are in the CDT manual, let's do a super quick recap. In our previous sessions, we focused heavily on preventative treatments, right? Those live in the D1000 to D1999 code range. Think back to procedures like routine cleanings, sealants, or the application of caries-arresting medicaments like silver diamond fluoride, which we code as D1354. All of those codes. They're entirely about stopping decay before it causes major structural damage. But today, we pivot. We're moving into Category 3, the restorative codes, which span from D2000 to D2999. These procedures, your fillings, crowns, and all those related restorations, they are all about restoring the function, shape, and overall structural integrity of a tooth that has already lost some of its structure to decay, wear, or trauma.
Moving on to Section 2, amalgam versus resin composites.
So here we're looking at the core material dichotomy in direct restorative dentistry. On one side, we've got dental amalgam. This is your traditional alloy mixture composed of liquid mercury combined with metals, typically copper, silver, zinc, and tin. On the flip side, we have composite resin. You'll often hear this referred to clinically and definitely by patients as white fillings. These are tooth-colored synthetic materials. Now, what's really fascinating here is how the code sets literally divide based on these exact material compositions. As a coder, your very first step when looking at a restorative operative report is to ask yourself, was this an amalgam or was this a resin-based composite? Because honestly, that single answer dictates which branch of the D2000 series you are going to go down.
Section 3, the mandatory inclusions rule.
Now listen, I want you to read through this list super carefully. Why? Because misunderstanding this concept is exactly what triggers so many painful payer audits. When a provider performs a restoration, the fee for that single code is entirely all-inclusive. You absolutely cannot unbundle or separately charge for the tooth preparation or caries excavation. You can't charge for the adhesives, the etching, the liners, or the bases. If the provider performs pulp capping during that same prep or places temporary restorations, buildups, or cement, guess what? It's all bundled. Impressions, laboratory fees, the actual filling material itself, polishing, occlusal adjustments, re-cementing, and yes, even the local anesthesia. All of it is baked right into that one base restorative code. This brilliantly illustrates the hard line the CDT guidelines take on compliance. You are billing for the completed restoration, which inherently includes the whole shebang required to get there.
Up next, Section 4, multi-surface coating logic.
Let's throw a practical, real-world clinical scenario into the mix. Imagine you're reviewing a chart, and the clinical notes state that a composite filling was placed on the buccal surface of tooth number 30. And during that same visit, another composite filling was placed on the occlusal surface of that exact same tooth. So, how do you code this? Do you bill one code for the buccal and a totally separate code for the occlusal? Take a second and think about the deductive logic we've been applying to our coding standards so far.
Well, if you guess that they must be combined, you hit the nail right on the head. The correct standard is to bill a single code representing a resin-based composite two surfaces posterior, which is D2392. You must never ever bill each surface separately when multiple restorations for the same tooth are treated. So the absolutely crucial takeaway here is that you have to consolidate the treated areas. You count the distinct surfaces treated, in this example 2, and select the single multi-surface code that matches that count. This strict rule preserves the integrity of the coding system and makes sure we get accurate reimbursement without artificially inflating a claim with a bunch of single-surface codes.
All right, Section 5, amalgam code breakdown.
Take a look at this beautiful structure for the amalgam codes, running from D2140 to D2161. It is purely mathematical based on the surfaces involved. Check it out. D2140 is for one surface.
D2150 is for 2 surfaces. D2160 is 3 surfaces, and D2161 captures 4 or more surfaces. Now, what's incredibly important to remember about this specific amalgam block is that these codes apply universally across patient age and tooth type. It doesn't matter if you're coding for an adult or a child, or whether the filling goes on a primary baby tooth or a permanent adult tooth. You use this exact same set of codes. The material and the surface count are the only things driving the code selection here.
But hey, knowing the right code is really only half the battle, right? To actually get that claim paid and avoid those frustrating denials, your documentation has to be completely airtight. Whenever you report D2140 through D2161, you are mandatorily required to report the specific tooth number on the claim, right alongside the exact surfaces being restored. Just putting D2150 simply isn't enough. The payer needs to know for sure that it was tooth number 30 on the mesial and occlusal surfaces. That documentation proves the medical necessity and validates the multi-surface code you just selected.
And finally, Section 6, Composite Code Breakdown. Now we're looking at our aesthetic, tooth-colored composite restorations, which span from D2330 all the way up to D2394. Now, unlike amalgam, the CDT manual strictly splits these into 2 major anatomic categories, anterior and posterior. For the anterior series, we're talking incisors and canines, teeth 6 through 10, 22 through 26, and their primary equivalents. You use codes D2330 through D2335, again based on the surface count. D2330 is 1 surface, D2331 is 2, D2332 is 3, and D2335 is for 4 or more surfaces, or if it involves the incisal angle. Oh, and there's also D2390 for a full anterior composite crown. But once you move to the back of the mouth for the posterior series, the premolars and molars, the codes shift completely. You'll use D2391 for 1 surface, D2392 for 2, D2393 for 3, and D2394 for 4 or more posterior surfaces. And while we're on the topic of full coverage, don't forget our pediatric full coverage restorations. For a primary tooth, a prefabricated stainless steel crown is coded D2930, and if it's got an aesthetic white coating on it, that becomes D2934. The anatomy of the tooth literally dictates which of these codes you pull.
Almost done. Let's hit the summary and our Part 20 teaser.
I really want to leave you with this thought today. Compliance relies on understanding the whole procedure, not just the surfaces. Mastering Category 3 restorative coding means knowing your materials inside and out. It means knowing exactly when to use an amalgam code versus a resin composite code. It means recognizing the absolute zero exceptions necessity of combining surfaces into a single code to prevent unbundling. And most importantly, it means remembering that the prep, the adhesives, the temporaries, and the local anesthesia are all part of the package deal. When you understand the procedure holistically, your coding becomes totally bulletproof.
We've spent a ton of time today talking about restoring the visible crown of the tooth. But what happens when the decay goes deeper? What happens when it actually reaches the nerve? Well, in Part 20, our final installment of the series, we are moving beyond the crown and diving deep into the roots as we tackle endodontics, the D3000 to D3999 codes. You are not going to want to miss it. Until then, stay focused, keep learning, and as always, decode healthcare with Harshal.